Ladies and gentlemen, InVivoScribe has been providing products for hemato-oncology research and diagnosis for over 25 years and is the proud sponsor of this webinar. We welcome you to this educational program organized by AMP, the Association for Molecular Pathology. Our program's title today is Lab Secrets, NGS-based MRD testing for acute lymphoblastic leukemia, the Austin experience. We are very pleased to announce the two accomplished speakers today. The first half of the presentation today is provided by Dr. Stephen Ma, a graduate of the University of Melbourne, serving as the laboratory Haematology Registrar at Austin Health. In addition to his medical degree, Dr. Ma is also an expert pianist, frequently performing at the Melbourne Recital Centre and featured live on 3MBS FM and ABC Classic FM. Dr. Rishu Agarwal will be presenting her work during the second half of the webinar. She completed her training in hematology through the Royal College of Pathologists of Australasia in 2016 and undertook PhD studies within the Molecular Biomarkers and Translational Genomics Laboratory at Peter MacCallum Cancer Center. The research undertaken, performed by Dr. Agarwal in mantle cell lymphomas during her PhD, defined novel therapies, resistance mechanisms, and molecular biomarkers, resulting in several high-impact publications, including Nature Medicine and the New England Journal of Medicine. Dr. Agarwal has recently been awarded 2021's Cancer Council Victoria Fellowship to identify blood-based biomarkers and define treatment response to targeted therapeutics in CLL.
Hello everyone, thank you for joining us. And we thank the sponsors first of all for the opportunity to present this webinar. Today, Dr. Rishu Agarwal and I will be presenting our experience at the Austin Hospital in Melbourne, Australia of next generation sequencing or NGS-based MRD testing for acute lymphoblastic leukemia. As a way of introduction, I will first talk about the prognostic value of MRD monitoring in ALL, as well as the various MRD detection techniques available to us and their associated advantages and limitations. I will then hand over to Dr. Agarwal, who will evaluate the NGS-based MRD testing technique in ALL with reference to its workflow, sequence analysis, sensitivity of clonality and MRD detection, as well as MRD quantification. Towards the end of the talk, I will come back and highlight some real-life case studies at the Austin Hospital supporting the potential utility of ALL MRD monitoring by NGS. Now, in Australia, there are more than 350 cases per year of ALL, which accounts for approximately 10% of all leukemias. As you can see from the blue line in the graph, that this is predominantly a pediatric disease, but we do get this second peak of incidence as age increases. The purple line, on the other hand, shows that the adult cases generally has higher mortality rate and worse prognosis compared to the pediatric cases. The diagnosis of ALL relies on morphology and immunophenotypic analysis by flow cytometry, but increasingly we're using molecular techniques such as cytogenetics, fluorescence in situ hybridization, or FISH, and sequencing technologies to help us characterize and prognosticate ALL, and this has implications on therapy. The genetic alterations in ALL are diverse, but via transcriptomic analysis, diseases can be segregated into distinct groups. This is a t-distributed stochastic neighbored embedding plot showing a variety of molecular subtypes of B-ALL. Each has certain disease characteristics. For example, the Philadelphia-like B-ALL lacks BCR-A ball translocation, but clusters together with Philadelphia-positive B-ALL by acquiring a diverse range of mutation that causes tyrosine kinase pathway activation. And this group has poor prognosis. It is important to note that such techniques are not available universally in routine diagnostics. Similarly, transcriptomic analysis has revealed the complexity of genetic alterations in T-ALL. I won't go into too much detail, but here we have age on the x-axis, and the heat maps show some differences between adult and pediatric T-ALL cases. As compared to its pediatric counterpart, the adult cases have upregulated BCL2, components of the receptor tyrosine kinase pathways such as FLT3, JAK1, and ABL1. In terms of treatment for ALL, chemotherapy remains a mainstay of induction therapy, and allogeneic stem cell transplantation remains the only hope of cure for the majority of our patients. However, we now also use tyrosine kinase inhibitors, various antibody and cellular therapies either as adjunct or standalone therapy in induction, consolidation, and maintenance settings. Despite the advances in therapy over the preceding few decades, there is still a wide discrepancy between complete remission rate, which is up to 90%, and 5-year survival rate of less than 50%. This means that a lot of our patients respond to therapy, but subsequently relapse. This is why disease prognostication is extremely important in ALL, as it helps us identify patients at high risk of relapse and helps us making the clinical decision of early treatment intensification, such as planning and proceeding with an allogeneic stem cell transplant, especially for fit patients. The traditional poor prognostic markers are listed here. A lot of these have underlying genetic underpinnings. We know that pediatric cases, for instance, are enriched with genetic alterations associated with good prognosis, such as hyperdiploidy and ETV6-RUNX1 translocation, whereas adult cases are enriched with those that portend poor prognosis, such as Philadelphia chromosome positivity, Philadelphia-like, and hypodiploidy. The graph on the right is an example that shows B-ALL cases with cytokine receptor-like factor 2 or CRLF2 rearrangement, which accounts for more than half of Philadelphia-like B-ALL cases. Patients with this particular rearrangement shows dismal survival rate as compared to cases without. Notably, a significant portion of patients of the so-called standard risk group in this cohort, shown as a lighter shade green line, also relapse. Clearly, we need additional prognostic markers to assist us. And this is where MRD comes in. We are moving away from the old terminology of minimal residual disease and now calling it measurable residual disease to reflect the fact that MRD negativity does not equal to cure and very much depends on the limit of detection of the laboratory assay that is used. Quantification of MRD may provide an estimate of reduction of disease burden as time goes on. This not only reflects the underlying disease biology, but also adequacy of treatment, drug resistance mechanisms, and other host drug interactions that may influence response. All of these may not be adequately captured by molecular characterization. Importantly, MRD monitoring identifies patients at high risk of disease relapse. This is a meta-analysis that clearly shows a separation of event-free and overall survival based on MRD status. MRD positivity identifies a group of patients with high relapse risk as shown with the blue curve here. In a real-life scenario, positive MRD may trigger the clinician to adapt therapeutic strategies. Again, as the grey line shows, MRD negativity does not necessarily equal to cure. Part of the reason why a lot of MRD negative patients still go on to relapse is that in those earlier studies, MRD negativity was defined as less than 10 to the minus 4. We now have more sensitive methods to detect MRD down even lower to 10 to the minus 6. The study published earlier this year showed that MRD less than 10 to the minus 6 identifies a group of patients with extremely low relapse risk, as illustrated by the blue line in the graph on the left. and this translates to long-term overall survival as shown on the right. So depth of MRD clearance clearly matters here. Furthermore, molecular risk factors need to be taken into account when interpreting MRD results. In this study by O'Connor et al., a relationship between specific MRD levels and underlying genetic risk is shown. Here, MRD level is shown on the x-axis, and darker shade illustrates higher relapse risk. The relapse risk at each MRD level is different for each disease group, and is lower for groups with good genetic risk, and higher for T-ALL and high-risk B-ALL groups, in this study as defined by cytogenetic lesions, such as KMT2A fusions, near haploidy, low hypodiploidy, IAMP21, and TCF3 HLF rearrangement. So a future relapse prognostication model must include MRD clearance depth, MRD clearance kinetics, as well as a molecular risk profile. Now this table shows how we detect MRD in ALL. First, we have multiparametric flow cytometry. It is rapid, relatively cheap, and tells you information about the whole sample cellularity. Although we can detect MRD level down to 10 to the minus 5 in many labs, the sensitivity can be variable. Significant expertise and fresh cells are also required. Then we have a number of different molecular MRD techniques. The most well-standardized assay is qPCR. It is very sensitive and highly applicable, but unfortunately quite time-consuming and relatively expensive. qPCR can also be applied to fusion genes such as BCR-ABL. This assay uses universal primers and is highly sensitive, but has very low applicability. Finally, we have NGS-based method, which has the highest sensitivity down to between 10 to the minus 5 and 10 to the minus 6, and is highly applicable. It has additional advantages of being able to track clonal evolution, as it assesses the whole cellular repertoire. It too has its own limitations though, such as relative lack of standardization, requirement of complex bioinformatic pipeline to digest the vast sequencing information generated, being relatively expensive, and requiring pre-treatment samples. The molecular MRD techniques we use today are based on the detection of clonal rearrangement of the immunoglobulin gene in B cells and TCR gene in T cells. This diagram illustrates the rearrangement of B cell immunoglobulin heavy chain in pro-B cells. You start with multiple variable diversity and junction gene segments. A specific D exon and J exon then recombine first, followed by the recombination of a specific V exon with the already recombined DJ exon. This generates a unique VDJ combination or sequence in each cell. As a malignant clone expands, a specific VDJ sequence can be detected in more abundance. The same principles apply to immunoglobulin light chain rearrangement in pre-B cells and TCR rearrangement in T cells. The end product of this immunoglobulin and TCR gene rearrangement process is the generation of an enormous diversity of unique gene sequences in the order of 10 to the power of 12. This forms the basis of specificity of particularly the sequencing-based molecular MRD methods such as NGS, as it is extremely unlikely that two clones will have the same gene rearrangement. This level of sequence diversity is further enhanced by somatic hypermutation that occurs in B cell development, which is important in NGS-based somatic hypermutation assays used in chronic lymphocytic leukemia. So to summarize all of this, rearrangement of antigen receptor genes which occurs during lymphoid proliferation, whether it's immunoglobulin gene or TCR gene, generates products that are unique in both length and sequence in each cell. Establishing the unique length or sequence allows differentiation between monoclonality, which is generally considered neoplastic, and polyclonality, which is considered as benign. A diagnostic clone, once identified, is usually followed during disease course, and this forms the basis of molecular MRD monitoring. This picture here shows a comparison between the various sequencing technologies for clonality assessment. On the left, we have Sanger sequencing. It has relatively low resolution because it only picks up the sequence of the dominant clone, hence the term bulk sequencing. This is in contrast to NGS in the middle, which allows massively parallel sequencing to generate high-resolution sequences from multiple clones at the same time. On the right, we have single-cell sequencing where one can trace the unique sequences obtained back to the original cells from which they come from. But single-cell sequencing is only available in research settings currently in Australia. Out of all the molecular IGH-TCR gene rearrangement assays I outlined earlier, PCR-based methods have been the gold standard for the last 2 decades. Euroclonality is a consortium that exists to establish guidelines to help standardize assay designs and interpretations, and it has published guidelines for PCR-based clonality assay for lymphoproliferative disorders about 10 years ago now. However, detecting lymphocyte or lymphoblast clonality by traditional PCR-based methods may not be straightforward. The squiggly lines in this diagram is a representation of the typical output of these methods. On the left, we have an example of polyclonality where many peaks are seen. These peaks are generated because DNA undergoes fragmentation analysis, and each peak essentially represents DNA fragments of a different length, as they are separated by capillary electrophoresis. In this case, there are no dominant peaks. On the right-hand side, we have an example of clear monoclonality where one peak is much higher than the rest, and this represents an underlying malignant clonal expansion. The example in the middle is a lot more tricky. This is an example of monoclonality in a polyclonal background. Although there is an underlying malignant clone, it is small and there are no dominant peaks, or in other words, the clonal peak is hidden. Usually one would cut out the gel at the corresponding position of the dominant peak and extract DNA for Sanger sequencing. Here, it would be very difficult to do, and even if sequencing information is obtained, it would be difficult to interpret. As a result, this technique may not be ideal or straightforward when it comes to MRD monitoring. So here's an outline of the pros and cons of the PCR-based testing. It is relatively simple, robust, rapid, and is highly standardized. It requires low DNA input and is relatively inexpensive. It also successfully exploits the size and overall composition of rearrangement fragments, with a sensitivity of between 5 and 10%. As a result, it is available and easily instituted into most laboratories. On the other hand, however, traditional PCR-based testing separates PCR products by the length of rearrangement, but not necessarily by unique sequences. As I've just explained, even if sequencing information is obtained by Sanger sequencing, it is often very difficult to interpret, particularly if the underlying clonal size is very small. In addition, it also has very low sensitivity relatively, and is therefore unsuitable for MRD monitoring purposes. So now I'll hand over to Rishu to talk about the NGS-based testing and its role in ALL MRD monitoring.
Thanks, Stephen, for the very nice introduction about ALL genetics and various techniques that are currently available for MRD detection. I'll be mainly talking about NGS-based clonality testing. Next-generation sequencing-based testing allows identification of full range of clonal population with underlying DNA sequences. As we get DNA sequences of all the clonal population, this reduces subjectivity in interpretation. It also allows us to detect clonal evolution at the time of disease progression or relapse. NGS-based techniques can be as sensitive as 10⁻⁻⁶. However, this depends on DNA input and read depth. There is definitely a potential for tracking residual disease. And NGS-based testing also helps us to identify somatic hypermutation status and clonal subtype for CLL. Euroclonality is a European foundation aiming to promote continuous development and standardization of laboratory diagnosis in hematology. Euroclonality developed and standardized multiplex PCR assays for detection of immunoglobulin and TCR gene rearrangements. These assays are widely used for the diagnosis of lymphoproliferative disorders for the last 2 decades. The Euroclonality NGS Working Group aims to research and set standards in IGS TCR NGS methodology and its application in hematology and immunology. The working group consists of approximately 20 diagnostic research groups. The main objectives of this group are to develop, standardize, and validate IGS TCR clonality assays for clonality assessment, MRD analysis, and repertoire analysis. A number of papers have been published recently by Euroclonality Group outlining primer designs, workflows, lab protocols, and bioinformatics to analyze NGS-based clonality testing. We are still waiting for formal NGS clonality guidelines, especially for assay interpretation, to be released. Few commercial assays are available to us for clonality testing, including in vivo Scribe LymphoTrack assays and Adaptive Biotechnologies clonoSEQ assays. These assays provide all-inclusive solution for clonal detection and disease monitoring in lymphoid disorders. We receive pre-designed primers, defined workflows, and bioinformatics software to establish and analyze clonality. We have validated LymphoTrack assays for diagnosis and disease monitoring in lymphoid disorders in our laboratory. The workflow is relatively straightforward. DNA is extracted from blood, bone marrow, or tissue biopsy. After that, extracted DNA is amplified with the help of primers. Once amplification is done, PCR products are purified, and then the final library is quantified. The final library is then uploaded into the sequencer, and FASTQ files are generated from the sequencers. We can upload FASTQ files into the bioinformatics software that is commercially provided and analyze for clonality assays. This slide shows an example of a polyclonal and monoclonal output. When a large number of reads have the same sequence, it likely means there were more than one of the original strand. And this is the basis of clonality testing by NGS. An overabundance of reads in one sequence when compared to a background of relatively low prevalence or polyclonal reads. We follow a specific set of rules to define clonality. Total read count should be more than 20,000 or at least 10,000. Q30 score should be more than 80%. Top rank sequence should account for at least 2.5% of the total reads. Or if the starting read count is 10,000, then at least 5% of the total read. And the top rank sequence should be more than 2 times the third rank sequence. Similarly, to identify somatic hypermutation status in CLL, we follow certain rules. If the sample is clonal, check whether the clone is productive or not and identify the mutation rate. Mutation rate of 2% is used to differentiate between mutated and unmutated CLL. Problems in interpretation often arises with minor clones meeting clonality criteria in a polyclonal background. This more common happens with T-cell malignancies than with B-cell malignancies. In this example, this patient came to us with a suspected diagnosis of LGL, large granulocytic lymphocytic leukemia. Flow showed a minor subset of T cells with a T-NK immunophenotype in the context of neutropenia for investigation. On clonality testing, we have also identified a clone constituting 6.83% of the total reads and meeting the defined monoclonality criteria. This can be a true clone or can happen due to few other reasons like low tumor content, low effective template, exaggerated T-cell immune response, And in such cases, we need to correlate with clinical details, histology, and immunophenotype for definitive diagnosis. We definitely need to better define oligoclonality, prominent peaks, etc. with this assay. This is a table from a paper that was published in 2019 in Molecular Diagnostics Journal, where authors have tried to refine the clonality assessment criteria in order to help better distinguish between polyclonality and monoclonality cases. And this is another paper about clonality criteria guidelines. This literature clearly shows that we need to better define clonality assessment guidelines. Hopefully, Euroclonality NGS working group will publish their recommended guidelines soon that we all can follow. To evaluate IGH clonality and MRD testing for ALL, we have included 26 BALL samples at the time of diagnosis, and then 81 serial time points were run for MRD monitoring. 8 non-clonal samples were also included in the assay to determine specificity. Replicate analysis was done for inter and intra-run precision. Sensitivity of the assay was identified with the help of the commercial control that was supplied by in vivo scribe, and the limit of detection of our assay is around 10⁻⁵. There was 85% detection rate of diagnostic clone in BALL cases. 4 out of 26 diagnostic BALL samples showed no evidence of clonality using framework 1, 2, and 3 primers. The underlying cause may be somatic hypermutations, incomplete rearrangements, or large gene translocation. One subject had translocation 14/19 involving the IGH gene, along with 11q abnormality. Another subject had IGH DUX4 gene fusion. 2 subjects had BCR-ABL translocations. We have submitted all 4 samples for whole genome sequencing and RNA sequencing to look for further underlying genomic changes that can cause these non-detection of clones. However, alternative MRD markers were present in all 4 subjects. We are also doing additional assays using leader primers and IG-kappa for further evaluation of these cases. These results suggest that NGS is complementary to other MRD techniques in ALL for routine diagnostics. Multiple clones or gene rearrangements are more common in T-cell malignancies as compared to B-cell malignancies. However, we have few BALL cases with multiple IGH gene rearrangements. We follow all clones that were detected at diagnosis for disease monitoring to see the effect of therapy on various clones. There is a possibility that one of the clones become the predominant clone at the time of disease progression or relapse, while other clones respond to treatment. We have not yet seen an example of this in our case cohort. With our workflow, we perform a clonality assessment at the time of diagnosis to establish tumor-specific DNA sequences through TRAC, using fresh or archived bone marrow or blood samples collected prior to initiation of treatment. And then diagnostic clone or clones are followed for disease monitoring. Evaluation of MRD status in ALL should be considered after induction, after consolidation, and at further time points during maintenance and follow-up. In general, MRD positivity at the end of induction or consolidation predicts high relapse rates and should prompt an evaluation for stem cell transplantation. Prospective MRD monitoring is usually recommended for MRD negative patients in 3 to 6 month intervals during maintenance therapy and follow-up. DNA input is very important for MRD testing. We use 3 replicates of 1 microgram each to reach to a sensitivity of 10⁻⁵ for MRD assays in our laboratory. Similarly, target clone selection matters for MRD testing. For IGH, due to high genetic diversity, there are no special consideration for selecting sequence for MRD tracking. However, with IgK, 3 common rearrangements are unsuitable for MRD monitoring. This includes intron KDEL, V3D20 with any J or K deletion, V311 with any J or K deletion. T receptor gamma are less diverse, and hence we should track exact sequences without any mismatch. For IGH gene rearrangement, we allow up to 2 mismatches. And in T-cell malignancies, there is strong propensity for biallelic rearrangements. Tracking 2 clones will reduce the likelihood of false positive match. We highly recommend using spike-in control for absolute MRD quantification in these assays. These controls help us to calculate clonal cell equivalents and provide us with accurate MRD percentages. The percentage given from the MRD software is the percentage of clonal reads divided by percentage of total reads, where total reads are B cells or cells with a rearranged IGH gene, as that is what is being amplified in the assay. This can be an issue where therapies have caused B cell depletion and patients have not yet count recovered. So we use a spike-in control method for normalization to express our MRD levels as a percentage of total cells. InVivoScribe have released a lymph count control with a known IGH rearrangement manufactured at 50 cells per microliter, which we spike into our MRD samples. And use this formula to normalize the levels. We see the values correspond closer to flow cytometry results. For example, in this case, without normalization, this particular MRD time point was 9.1% of the total read. With normalization, the value was 0.02065%, which was more in corresponding with the flow cytometry results. So in conclusion, without normalizing the MRD levels, we can greatly overestimate the MRD values. For MRD, we can track up to 5 clones at a single time point with the available MRD software. This is an example of the case where patient has responded very well to the treatment and the MRD was negative at serial time points. And this is an example of a B-ALL MRD positive case that has subsequently relapsed. Now I'll hand back to Stephen to share Austin's experience with ALL MRD monitoring evaluation. Thanks.
Thanks, Rishu. Now I will share some of the data we have collected on ALL MRD monitoring using NGS-based IGHV and TCR gene rearrangement assay in the last 2 years. We started with 23 subjects. Of these, 19 subjects had IGHV or TCR rearrangement detected at ALL diagnosis. This corresponds to a sensitivity of 82.6% for clonality detection at diagnosis. The reasons for non-detection were outlined earlier. So now we end up with 75 MRD time points for 19 subjects, where we have paired samples for flow and NGS. The concordance rate between flow and NGS assays was 78.7%. Interestingly, 100% of the discordant samples were due to NGS detecting MRD levels below the threshold of flow cytometry, and there were no samples where MRD was undetectable by NGS but detectable by flow. This reflects the enhanced MRD detection sensitivity of NGS compared to flow, but more importantly, this higher sensitivity is clinically significant and not false positives. So I will now show you 4 case studies to illustrate the clinical utility of NGS MRD in ALL. Case study 1 is a 22-year-old female with B-ALL. At diagnosis, she had a Y cell count of 10 and a bone marrow aspirate showing 94% of lymphoblasts. Her karyotype is listed here, and FISH analysis showed a TCF3 PBX1 translocation. She had monoclonal rearrangement detected on the NGS and went on to have modified BFM 2000 induction protocol along with blinatumomab up front. Here we have serial flow MRD levels in the blue column and NGS MRD levels in the yellow column. As you can see, this subject achieved MRD clearance by flow following induction therapy, but low-level MRD reappeared 1.5 months later. The January time point is a critical one, where NGS detected MRD persistence at 10 to the minus 6 and flow MRD was undetectable at the same time. Over the following 3 months, MRD levels rose and eventually she relapsed. Her salvage therapy then consisted of inotuzumab and CAR T-cell therapy, but unfortunately a brief complete molecular remission was followed by a second relapse and she eventually died. This case study is an example of NGS MRD being able to detect lower MRD levels than flow and heralded disease relapse and a poor clinical outcome. Case study 2 similarly showcases NGS as a more sensitive assay in detecting MRD. This is a 52-year-old man with relapsed B-ALL 1 year post an allogeneic stem cell transplantation. Following relapse, our subject received mini-hyper-CVD, blinatumomab, and inotuzumab sequentially. The persistence of MRD led to the initiation of donor lymphocyte infusions. In the 4 months following, NGS consistently detected a persistence of MRD between 10 to the minus 4 and 10 to the minus 5, whereas flow missed MRD at 2 of the 3 time points. If you look more closely at the March 2021 time point, which is the 4th row from the top, there was a 1 log rising MRD level from the earlier time point, and this reached above 10 to the minus 4 threshold for flow, hence the flow detection at the time. And a month later, when the MRD level went 1 log back down again, flow was unable to detect MRD. This is a clear indication of the limit of detection difference between the 2 assays. Again, the MRD persistence as detected by NGS predicted subsequent relapse, and this patient eventually died some months later. Case study number 3 is a fascinating one. This is a 55-year-old female with B-ALL and had a Y cell count of 18 at diagnosis and a bone marrow aspirate showing 95% lymphoblasts. Cytogenetically, she was shown to have hyperdiploidy. As you can see, the MRD level fell as treatment continued, but was still detected by the end of cycle 2A hyper-CVAD. This led to a change of treatment to blinatumomab for MRD eradication, and this strategy worked, and this subject went on to receive an allogeneic stem cell transplant. She has had undetectable MRD since then and remained alive and well. What's interesting in this case is that whilst the clone that was detected at diagnosis disappeared, as the MRD levels have shown, a new clone emerged at a later time point. This indicates clonal evolution. However, the significance of this is yet to be determined, and we are currently in the process of collecting further clinical and laboratory data. Case study 4 is a perfect example where MRD persistence as detected by NGS led to major clinical decisions. This is a 57-year-old man with B-ALL with a Y cell count of 10.9 and 84% lymphoblasts in the bone marrow aspirate at diagnosis. Cytogenetic and FISH analysis confirmed a dicentric 920 translocated chromosome, which resulted in biallelic deletion of CDKN2A, which predicts poor outcome. He also had biallelic IGH rearrangement detected by NGS. If you focus on the yellow NGS MRD column first, you will notice that MRD level went right down to 10 to the minus 5 after cycle 1A hyper-CVAD. But as treatment went on, the MRD level slowly rose again. And this prompted a switch of therapy 4 months after diagnosis to blinatumomab with the aim of MRD eradication. MRD was undetectable after only 1 cycle of blinatumomab, but re-emerged after cycle 2 and rose post-cycle 3 by 1 log. This led to urgent allograft assessment and consideration for CAR T-cell therapy. Unfortunately, there still are no suitable matched donors for this subject, and he was deemed not suitable for haploidentical allograft or CAR T-cell therapy in a trial setting due to his many comorbidities. We are still actively tracking his progress currently. Strikingly in this case, flow cytometry did not detect MRD at any of the follow-up time points. Therefore, the relevant clinical decisions could not have been made promptly without NGS MRD. Now that I've highlighted the power of NGS in ALL MRD monitoring, I'd like to briefly outline some of the pitfalls as well. NGS is a relatively new technology and unfortunately is not readily available in all laboratories. There is a need to redefine clonality due to the high depth of resolution. This is particularly the case in T-cell malignancies, and Rishu has touched on this issue earlier. Part of the solution is to establish a healthy individual and reactive conditions dataset to help us set the so-called clonality threshold. The analytical phase of the NGS MRD assay still requires extensive validation and standardization, but we know that Euroclonality Consortium is putting a lot of focus on this in recent years, and there will likely be further publications upcoming. Pre- and post-analytical phase variables are important and will help interpretation of results. These variables include clinical context, the selection of representative material, including its quality, the way we handle our samples, isolate our nucleic acid, and selection of immunoglobulin or TCR gene targets. The accurate interpretation also depends very much on individual experience and detailed knowledge on not only the technology itself, but also the underlying disease process. In summary, MRD monitoring has the potential to be integral to ALL disease prognostication, along with molecular markers. And as we know, more and more often zero MRD levels are now used to guide clinical decision-making. NGS has shown in this space to be complementary to other standard care MRD monitoring techniques, such as multiparametric flow cytometry and allelic-specific oligonucleotide PCR techniques. The advantages of NGS include increased sensitivity, the use of universal primers, as well as the ability to track clonal evolution. Normalization of MRD levels to cell equivalents also facilitates comparison of results, as well as correlation with MRD levels obtained by other assays. However, I must stress that in interpreting MRD levels, clinical pathologic correlation and sample quality are of paramount importance. Lastly, NGS-based MRD monitoring is a powerful tool to aid ALL clinical trials and the development of in vitro diagnostic medical devices on NGS platforms. And these have the potential for improving decision-making in ALL in the era of personalized medicine and precision oncology. So finally, thank you for listening, and we hope you've enjoyed our discussion today.
On behalf of InVivoScribe and AMP, we want to thank everyone for your attendance today at this webinar. Please note that a recording of this webinar will be sent to all registrants and any questions will be addressed in a follow-up email. We would especially like to thank Dr. Ma and Dr. Agarwal for their excellent presentations and for sharing their experiences. Thank you.